All right, let's jump right in. We're going to map out exactly how to conquer that next ward page about ventricular tachycardia. We all know the feeling. That pager goes off, your heart rate spikes a bit, and you need a mental framework that just works under pressure. Well, this explainer is going to give you exactly that, turning a mountain of dense medical data into an instant, actionable algorithm. We're going to break this whole thing down branch by branch. We'll start with the initial 30-second fork in the road, then look at managing non-sustained VTAC, tackle the sustained monomorphic kind, review our antiarrhythmic arsenal, and finally, prep for those absolute worst-case scenarios. So, let's start with Section 1, the 30-second fork in the road. Picture this. You get paged, and before you even glance at a medication list, your very first step is figuring out which side of the flowchart your patient is actually on. And time is the ultimate threshold here. Anything under 30 seconds means you're playing by one set of rules, and anything over 30 seconds triggers a totally different protocol. Less than 30 seconds is non-sustained, greater than 30 seconds is sustained. It's literally that simple. But getting this single metric right is absolutely crucial for everything else that follows. Moving right along to Section 2, managing non-sustained VTAC. Now that we know the thresholds, let's head down the non-sustained branch. Honestly, you're going to see this constantly on the wards. Patients throw 5 or 10 beat runs all the time. The golden rule here? Universally check and replace their electrolytes. Because, sometimes simply fixing some out-of-whack potassium or magnesium just completely solves the problem. But your actual next move hinges entirely on one thing: symptoms. If they're totally asymptomatic, just sit on your hands. You really don't need to do a thing. But if they're feeling it, if they're complaining of palpitations, dizziness, chest pain, that's when we initiate medical therapy. If they are symptomatic, you're going to follow this highly logical escalation pathway. Step 1, start them on a beta blocker or a calcium channel blocker for simple rate control. Now, if the heart is stubborn and refractory to that, step 2 is moving up to amiodarone. And finally, step 3, if they're still refractory despite all the heavy-duty meds, you start pursuing catheter ablation. It's a really steady step-by-step climb from simple medications all the way up to structural interventions. Actually, hold on. Before we go any further down this pathway, we need to hammer down a vital definition. How many beats actually make a run? Just 3. 3 consecutive premature ventricular contractions, or PVCs, officially constitute a run of VTAC. Not 5, not 10, literally just 3. That is the universal standard for when isolated skipped beats cross the line into a tachycardia. And here's a number you really want to keep in the back of your mind: 10%. If more than 10% of a patient's total daily heartbeats are PVCs, their risk of deleterious cardiac remodeling absolutely spikes. It's a real game changer. It means you might actually need to intervene just to protect the heart muscle from long-term structural damage, even if the patient is sitting there totally asymptomatic right now. You also need to keep a sharp eye out for the rules of malignancy on the EKG. These are huge red flags strongly predicting that a simple PVC is about to trigger a dangerous run of VTAC. First, watch out for frequent PVCs. Second, look for multiform PVCs, meaning they're firing from completely different spots in the heart, so they'll look totally different from one another. And third, the dreaded R on T phenomenon. This is a massive deal where the PVC fires right on top of the vulnerable T wave of a normal QRS complex. It basically sends the heart into an instant, chaotic tailspin. All right, let's jump back up to the top of our tree for Section 3, tackling sustained monomorphic VTAC. So, the patient has been in this rhythm for over 30 uninterrupted seconds. The stakes are definitely higher here. This brings us to our next major clinical fork in the road: hemodynamic stability. It's a rapid, binary triage. Unstable patients get shocked. Stable ones get medicated. Is their blood pressure tanking? Are they altered? That dictates everything you do next. If the patient is unstable but awake and you actually have a minute to safely sedate and set things up, you're going to perform a synchronized electrical cardioversion. And the magic number here? Exactly 100 joules. It's targeted, it's synchronized, and honestly, it's usually highly effective. However, and this is a big however, if they are pulseless or significantly unstable, meaning they are crashing right in front of your eyes, do not wait. Skip the finesse. You start your shock directly at 200 joules and titrate rapidly up to a maximum of 360. That's the aggressive, no-nonsense protocol to immediately restore a life-sustaining rhythm for a dangerously unstable patient. Which brings us right into Section 4, the antiarrhythmic arsenal. When the patient is stable but stuck in that dangerous sustained rhythm, we reach for the IVs. And this breakdown
This is your ultimate pharmacological cheat sheet for the wards. It tells you exactly what to order and why. Amiodarone is your absolute default. You push a 150 milligram bolus over 10 minutes, then follow it with a continuous drip. It's got a slightly slower onset, sure, but the reversal rate is incredibly high, and it's fantastic at preventing recurrence. Then we have lidocaine. Why use it? Well, its overall reversal rate is actually pretty low, just 10 to 20%, but it causes the least amount of hypotension, and it's uniquely great if the patient is having an active myocardial infarction. And finally, procainamide. It successfully reverses VTAC about half the time, but it comes with this amazing bonus. Even if it completely fails to break the rhythm, it physically slows the heart rate down. That is a massive clinical win for preserving their cardiac output.
Now, from a purely practical ward management standpoint, here is a golden rule. Do not just leave the drip running aimlessly once the rhythm breaks. I see this a lot. If the VTAC terminates during the infusion, you stop the therapy right then and there. You only restart it if the arrhythmia rears its ugly head again. This keeps your management super precise and minimizes drug toxicity. And remember, even if they started out completely stable, your ultimate fallback for medication-resistant VTAC is always the defibrillator. Do not hesitate to electrically cardiovert if the drugs are failing and the patient is just lingering in that danger zone. Electricity is your ultimate safety net.
Let's finish up with Section 5, worst-case scenarios.
We need to look at the absolute most stubborn rhythms, the terrifying clinical situations you'll face at 3 a.m. when the standard protocols just aren't cutting it. First up is VT storm. You need to instantly recognize these diagnostic criteria so you can escalate care immediately. VT storm is exactly defined as either 3 or more episodes in a single 24-hour window, or a rhythm that just keeps bouncing back within 5 minutes of you successfully terminating it. It is a highly volatile state. Now contrast that directly with this distinct phenomenon, incessant VTAC. This is where the rhythm just stubbornly refuses to break for hours on end. Yet, bizarrely enough, the patient somehow manages to maintain their blood pressure and stay hemodynamically stable. The heart is just racing nonstop, but the system hasn't crashed yet.
So, in either of these nightmare scenarios, VT storm or incessant VT, if the patient is already maxed out on amiodarone or another antiarrhythmic, your definitive next step is adding a beta blocker to the mix. Specifically, propranolol is your preferred choice here. Why? Because it's proven incredibly effective at forcing termination of these super stubborn, sympathetic-driven rhythms. It literally helps snap that vicious cycle. So, here's the real question. When your pager goes off tonight, are you ready to navigate this decision tree with total confidence? You now have the exact structured algorithm you need to assess, triage, and treat this complex condition without a second of hesitation. From that crucial 30-second rule, through the nuances of the antiarrhythmic arsenal, all the way to managing a full-blown VT storm. The framework is right there in your hands. How will you use it to save a life?